Good afternoon, everyone. On behalf of the Duke Margolis Center for Health Policy and the United States of Care, I'd like to welcome you to today's webinar on value-based care in the COVID-19 era. I'm Mark McClellan on behalf of the Duke Margolis Center for Health Policy. I'm pleased to have be joined here today by Andy Slavitt, my friend and former acting administrator for the Center for Medicare and Medicaid Services and founder and board chair of United States of Care, which is a collaborator in our event with us today. We're going to hear from Andy in just a couple of minutes. In addition to our partnership with the United States of Care, this webinar is made possible with support from West Health and is part of a collaboration between Duke Margolis and West Health to advance and accelerate value-based care and payment reform with the goal of improving health, reducing health disparities, and making care that meets people where they are more affordable and accessible. Last week, as part of this effort, we released a couple of roadmaps at the federal level and state level describing paths to advance value-based care. And the goals of value-based care seem particularly relevant now at such a difficult time for the United States. Healthcare organizations have really struggled under fee-for-service payment during the pandemic because they're seeing far fewer patients in the traditional visits and procedures. But at the same time, they're struggling. We really need their help, certainly in responding to the surges and outbreaks where the work of hospitals and frontline providers has been absolutely critical in responding to the pandemic. But we also need their help in new ways of delivering care, virtual care with telehealth, shifting care from hospitals and institutions to home and community, and even for specialized services like chemotherapy or chronic disease management, as CMS emphasized in its guidance for reopening healthcare released just yesterday. And also in delivering mental health services and food and other necessities to seniors and others who are isolated at home and otherwise at risk of costly health complications. And in augmenting the nation's ongoing efforts to contain the virus, we need their help as well by identifying the patients who are at risk of COVID-19, by helping those patients take steps to avoid infection, by helping with testing and tracing and containment in collaboration with public health officials. All of these are really important reforms in responding to the pandemic. Many of them should probably be continued after the pandemic, but few of them are well reimbursed under traditional fee-for-service payment models. Now, you'll hear more shortly about some of the steps that have been taken, some of the intensive and unprecedented steps by Congress and particularly by the Centers for Medicare and Medicaid Services to provide support and flexibility for healthcare providers during the pandemic, including more funding for hospitals and other providers and other new ways of paying for some of these types of care. These are important steps. Further actions are planned, and we'll talk about those as well. We do think further steps are needed, especially for primary care practices, mental health organizations, many specialists who are needing to deliver care in new ways, and also rural healthcare providers in adapting to these new kinds of care models. So we're releasing a few documents in conjunction with today's events. First, in conjunction with our friends at the United States of Care and a bipartisan group of 4 other former CMS administrators, we're releasing a proposal for assisting providers in the pandemic that builds on the payment and regulatory flexibilities we've seen so far and uses what we've learned about value-based care arrangements in this public health emergency. We propose some additional payments for providers who participate in these key activities and also provide a path forward for them so that they can make investments and see a path to retaining and building on these kinds of care capabilities as we move beyond the pandemic and hopefully don't return to a healthcare system like the one we had before, but a better one. These reforms can also help address health disparities and health equity, something that deserves much more attention today and going forward. We're also releasing an issue brief on how organizations who receive value-based payments are responding to the pandemic already. Because they're in better financial shape and have these payment flexibilities both now and into the longer term, they've been able to make more investments now in building the kinds of healthcare that we need to respond to the pandemic and to build that more resilient healthcare system for the future. So we're going to cover a lot of these topics today. We'll talk about how healthcare organizations are leveraging value-based care in the COVID-19 context. We'll hear directly from organizations that have been engaged in these efforts, and we'll hear about some ideas to build on them for the future. So to get started, I'd like to turn to Andy for a few opening comments as well. Andy, it's been a pleasure working with you. The US of Care has had a remarkable impact in its short life. It's got very broad impact with bipartisan support from almost 100 Founders Council members and other advisors. I don't know how I made it on that list, but Andy, it's been a pleasure working with you. And thanks for joining us today and for helping in this important collaborative effort.
Thank you, Mark. On behalf of United States of Care, I want to thank you and the Duke Margolis Center, as well as West Health, who's a terrific forward-looking voice and partner as well. We're at an incredibly interesting moment of time, and I applaud Mark and the team for taking the opportunity to ask some fundamental questions that I think are going to be begged of us going forward. I think we are going to be looking back on this time period and asking, what could we have done differently? What could we have done better to be more prepared? What can we do better next time? And probably most immediately, how do we make sure we have a health system that responds to the needs coming out of COVID-19 and coming out of the significant trauma of racial violence that has been afflicting the Black community? Those are questions that I think we're all going to be asked to answer. And one of the things that I think when we talk to folks that is worth having an open conversation around is what would be different today if healthcare providers were paid in a value-based arrangement? Would they be better positioned to serve the community? Would they be better positioned to invest in prevention and the creative resources needed to deliver care at home through telemedicine? And would they, in fact, be better positioned to work on some of the important prevention, diagnostic testing, and other things that are going to be so needed? And should we not use this moment in time to say that we should come out of this a better healthcare system than we went into it? And to do that, I think it's important for people to take a look. I think it's useful to take a look, I should say, at the letter that Mark spoke of, some of the materials, but even more interestingly, to hear from some of the people that you're going to hear from today. So let me quickly walk you through the agenda. We're going to begin with a fireside chat that Mark is going to host with CMS Administrator Seema Verma, who is both of our predecessor, and talk about the work that CMS has done to support providers during COVID-19, as well as CMS's vision for supporting value-based care for the longer term. I think we'll also probably touch on health equity issues that are so important to everybody right now. Then our next session, we're going to hear from some of the leading healthcare organizations and providers that are engaged in value-based care and talk about how that has changed their ability or impacted their ability to deliver high quality care during the pandemic and beyond. So I think that will be a critical conversation. Following that, we're going to have another fireside chat with the director of CMMI, Brad Smith, I think, which will be fascinating, and to discuss how CMMI is continuing to support value-based care in the context of COVID-19 and what's next. Finally, we'll have a final session where we'll hear from some of the policy and payment experts about what the actions are needed to encourage and support providers going forward. So it's going to be a very full conversation, and I think we should get to it. So let me get it back to you, Mark.
Great, Andy. Thanks very much. I look forward to hearing from you again in a few minutes. And right now, I'm very pleased to introduce Seema Verma, the administrator of the Centers for Medicare and Medicaid Services. Administrator, thanks very much for joining us today.
My pleasure. Good to see you, Mark.
Well, we wanted to do this as a dialogue, and I guess I should start with the big question. You all have at CMS have had to do so much in this public health emergency. So CMS is always there for flexibilities and new arrangements when there is an emergency, but we've never had one like this, the entire country to this extent over this period of time. CMS has put out a really good summary of all these flexibilities for our providers joining us today. It's a great resource on the website. But out of all of that, what do you see as some of the most important elements and the biggest themes that you've taken through this pandemic response?
Well, you're right. I mean, the agency really acted with historic speed and action. As you know, it takes a while for us to get a rule out the door, sometimes years. But we just did these in a matter of weeks, and credit really goes to the strong team at CMS. It literally was just working round the clock, weekends, 15, 17-hour days for weeks on end. So, I think there was a lot of important lessons. There was a few areas that we focused on: testing and telehealth, initiative that we call Hospital Without Walls, to really ensure that there was the capacity of the healthcare system to deal with the increased volume. Also focusing on workforce. And so going through all of those things, it really began to have some discussions about what is really needed in some of these discussions. So as we were thinking about, okay, we're going to waive this, waive that, we're now having the conversation to say, do we really want to put some of these things back in place? And then there are some that are clear that, as soon as the public health emergency goes away. I think the best example of this is around telehealth. We've been working on telehealth even before the pandemic. And so, very early on, at least there was a foundation. We had started paying for some virtual visits and across the country, even just short, brief encounters. But we really have seen a massive increase in telehealth across the board. I was just looking at the numbers yesterday that we've had some, over 7 million beneficiaries trying telehealth services, especially for just those routine evaluation and management visits. And so I think that's a great example of something that we probably should have conversations about continuing for the future.
Apologize, I'm having a sound issue.
I can hear you, Mark.
Yeah, my next question for you was about as the healthcare providers start to reopen, what do you see different? What would you like to see different, and how is that going?
Well, one of the things that we're hearing from providers is that actually it's slow coming back. I think there was a lot of concern that we would see this, big increase in utilization. And again, providers were concerned about that, but we're still seeing that patients are reluctant to come back, and it's been slow progress. Obviously, in some areas of the country, that's different, but generally, we're not seeing the type of increase. I think one of the things that we want to make sure that we're maintaining, obviously, we talked about telehealth, but I think just some of the efficiencies, and we're, like I said, whether it's giving some more flexibility for pharmacists to do testing as an example of some of the things, even, our work over patients over paperwork. We probably put out 136 waivers of federal regulations. And so some of the flexibilities around workforce, and we know that those have been long-standing issues. We want to make sure that the federal government's not standing in the way of using more of our paraprofessionals. I think that could address a lot of workforce shortages issues across the country. So that's another example of things.
So it sounds like reopening should look a bit different than care before. Many patients are understandably concerned about coming back out if they've got risk factors, and CMS had, I think, some guidance out yesterday about reopening that was encouraging providers to try to treat these patients at home and meet them where they are. Are you seeing that starting to happen? And it sounds like it would be a...
Yeah, we're seeing a lot of innovation from providers, things like instead of having people come into the office in an office waiting room, they're having them wait in their cars. A lot of them are not scheduling a lot of patients all at once, or trying to stagger their providers, so they're not coming back full force. Obviously, there's going to be the increased use of PPE. There's more screenings on the front end in terms of temperature checks. And then just more testing of patients as well as healthcare providers as well.
Yeah, and I know you've implemented some payment reforms intended to help healthcare providers get more involved in those containment activities, the testing, the outreach to their patients, and help with treating patients who have COVID-19 at home, and the contact tracing. How's that going?
Well, that's something that we continue to work on. I mean, obviously, there's going to be a reliance on local public health departments, but I think that, in order to really have this move at the speed and the pace that we need to have it get done in terms of contact tracing and the testing, we have to rely on the private healthcare system that we do have in place. And I think the local health department, to some extent, is going to be a part of that. But I think it's just all hands on deck. And so some of the conversations that we've been having are, how can we look at our existing payment systems, and are there ways that we can try to leverage the private healthcare system around contact tracing, around testing, to encourage that? So you're going to see more from us on that. I just think it's important that we not exclusively just completely rely on the local public health system. I go way back and worked in a local health department back in the day. And so I just feel they have been traditionally under-resourced. The federal government is now putting in a lot more into our local health system, and we're hiring a lot more contact tracers across the country. But I still think that the private healthcare system has a large role to play in this.
And while all this is going on, so more engagement of health and support for healthcare providers, getting out there in the community and helping with testing and containment, more support for the home care, more support for people who have been more isolated at home. This is all happening, as Andy mentioned earlier, in the context of a real national crisis related to racism and equity and differential access to needed treatments, and some emerging big racial differences, Black Americans, Latinx Americans, with respect to the incidence of COVID-19 and the outcomes. Do these reforms fit in with your response to those issues as well? Are there synergies there? What's going on in CMS's responses to these big concerns about health equity? I know you're doing a lot.
So one of the things I'll say is that I think with the COVID virus, it's exposed what works in our healthcare system and what doesn't work, and where the problems are. Excuse me. What we see is that we've always had in our healthcare system long-standing healthcare disparities, and so COVID virus is no different. I think what's important to understand with these disparities is that there are a lot of underlying reasons. We continue to look at our data, and it certainly supports that African American communities, Hispanic communities, Asian American communities have all been hit hard. What's interesting is to also look at what are some of the underlying reasons. These are not genetic reasons. These actually have a lot to do with some of the social determinants of health. And when you start to get into the data, there's also a lot of linkages to people living in poverty. And so when we think about disparities, a lot of that across the board also has to do with those social determinants of health. And so as we're trying to address it, it's not just addressing healthcare issues, but that larger context. So we've always been focused on trying to improve health outcomes. And so when you're trying to improve health outcomes, you have to look at all the underlying factors, and race, income. One of the things that we just saw, and we'll be putting out some more data on this, we're starting to now get a pretty robust numbers of claims that are coming in around COVID virus. So they just in April provided the code for the COVID virus. Prior to April, we had difficulty really understanding what was going on. But now, since April, plus providers are submitting their claims, we actually have a pretty good picture. And what we're seeing is that in the Medicare population, the group that's been really hit hard are dual eligibles, those that are eligible for both Medicaid and Medicare, that they're the ones that have really seen higher hospitalizations, and that seems to be more of an issue rather than race. So again, as we talk about the issues of disparities, it's complex, and there's many factors to that.
And out of all of these activities that are underway, so your analysis of the data, getting a better understanding of these racial differences and other differences in high-risk groups like dual eligibles, the payment reforms around telehealth, around site of service, around scope of practice, and supporting additional healthcare providers like pharmacists. What are you most concerned about? What would you like to convey to providers as we move into this next phase of the pandemic, where we are trying to reopen, but we are seeing outbreaks and in some states, increasing number of cases? There are concerns about potential wave in the fall. How can we keep building on these steps, and how can providers help make sure we've got an effective response through reopening and potential future waves?
I think the most important thing for us all to understand is we can't keep our eye off the ball. I think the American public has done a great job with some of the, with the requirements around staying at home orders and social distancing, but you can see that the country's getting, it's hard and it's difficult, and that people are, frustrated staying at home. So I think it's important for the healthcare system that we all sort of work together to emphasize how important that is. I think we all should be very mindful about what we might see in the fall. In the fall, we're also, as we normally do, you see the flu come on as well. And so I think that we're trying to really keep our eye on that as well. I think the data is also bearing out actually what we knew from the very beginning, which is that our older adults are particularly vulnerable. We just put out nursing home data about a week ago that really showed that devastating impact that, the data is still coming in, but my guess is it's going to be around 35, somewhere between 35 and 40%. If we look at all the deaths in this country, will be related to nursing homes. And so that's also kind of a call to action to all of us about where we need to focus and do what we can to support the nursing home facilities and also the residents and families that are impacted by nursing homes and assisted living facilities.
So you've talked about some of the challenges ahead and how you're preparing to address them. I've also heard you talk a number of times about how many of these flexibilities seem like features you'd like to see in payment systems and supporting care delivery, even as we go beyond the pandemic. I don't think for many Americans, I think they'd like to keep up this shift to telehealth where it works well. And it does offer these shifts do offer some opportunities to get care more out into the communities where you're closer to people and closer to those root causes of health problems. Can you say a little bit more about how you're thinking about where to go from here? So we've got some challenges ahead in the coming months, but to get to a better, more resilient healthcare system, as Andy was talking about, even beyond the pandemic.
Sure. So, and you and I have had many conversations about value-based care. Our priorities haven't changed in terms of fostering innovation, creating a more competitive environment, whether it's site-neutral payments, whether it's price transparency, quality transparency, and really pushing towards more innovative payment models, lowering drug prices. None of that agenda really changes because of COVID. I think it also stresses the urgency for us working on those issues, because there is more stress on the healthcare system, and the reforms that we've been talking about for many years are important to that as well. So let me talk a little bit more about value-based care, and I know, Mark, that's one of your favorite topics. If we were in a system where there was more capitated care and providers had more stable, predictable revenue, we wouldn't be having a lot of the challenges that we're having right now. And so I think that the call for action around moving towards value-based care, and and I've said it before, I think it's moving really slow, and we need to expedite that. That would actually help prepare the system in a much better way than really anything we can do to give them those opportunities to have stable, predictable revenue and tying that to quality and outcomes. I think one of the things that I'm learning from this whole experience is, because we did put over 136 waivers out there, and just got rid of a lot of regulations that probably stand in the way of providing good care. And I think those are lessons for the agency, that as we are developing and pushing towards value-based care, that we think about those flexibilities and provide more. So all of the models that we put out there, they give you a few, they give you some stark law flexibility, some waivers there, and we're trying to fix that on another end as well. But in terms of telehealth, we did a little bit of that, but I think there's a complete opportunity to do a lot more around providing more flexibility, whether it's things on workforce, simple things like, bed limits in rural communities and some of our critical access hospitals. So, from our end, I think there's an opportunity for us to really think and really increase the amount of waivers and flexibilities to attract more providers to value-based care. I think it'll help them do their jobs better and provide more quality and accountability for the whole system.
And following up on that, as you said, it certainly seems like there are lots of providers in this pandemic crisis who would much prefer to not be on fee-for-service payment, to have a more predictable payment stream with flexibility to implement these new approaches to care. Do you think, from the providers you've been interacting with, are there some out there who would like to continue that sort of arrangement? So maybe as we move beyond the pandemic, not go back to fee-for-service, maybe get more of their revenues on more of a provider level, or, as you said, capitated level, in return for, in conjunction with, keeping a lot of these flexibilities?
Well, certainly, I think one area which is very ripe for this is rural health in rural areas. I always talk about a competitive marketplace and making sure that government's role is to set the rules of the road so that competition can flourish. Well, that obviously doesn't translate well into rural areas. We obviously want to create incentives for providers to provide a better quality care at lower cost. But I think in rural health, I just don't think a fee-for-service system works there. And this is really, there's a lot of promise for value-based care. We're seeing rural hospitals across the country close down, and providers are really struggling. The ones that are there operating on very thin margins. And we need to make sure that we have a sustainable healthcare system for all Americans, including those that are in rural areas, and changing the payment models, even thinking about new types of entities. We've heard some conversations about freestanding ERs, and actually during the emergency, we've allowed for some freestanding ERs to be reimbursed under the Medicare program in certain areas of the country. That might be something I'd like to see it be more than ERs, and have it also address things like primary and preventative care. So I think that this is an opportunity, and it's almost kind of forcing us to rethink our whole rural healthcare system and how we pay those providers to ensure that it's stable and that people have access to high quality, affordable care.
Yeah, interesting. So we talked about how public health emergencies come with authority for CMS to do a lot of things that it can't easily do with its current legislative authority under normal times. Is there a role for Congress in helping to advance some of these ideas? I know that CMS has more flexibility to continue these kinds of programs like telehealth, site of service, in the value-based payment models, but is there a role for Congress here too?
Well, I think in order to sustain some of these, we will need Congress's help, especially in the area of telehealth. I think that's one where it's not just allowing the services, but making sure that it can be provided in different sites of care, that different types of providers can provide care. And sometimes there are even laws that require you to have face-to-face visits. So kind of collectively looking at telehealth. I think the other area that Congress can be particularly helpful on is we're thinking about telehealth as practicing across state lines. So we provided waivers that allowed Medicare providers to be reimbursed regardless of where they were providing care. So those kinds of things, I think we would need Congress to step in as well. Some of the site neutral payment things, I think, are very important to having a competitive marketplace. We've been working steadily to ensure, for example, our surgery centers, that they have more flexibility. And during the public health emergency, we are paying them as hospitals. And we wanted to do that mostly to make sure that communities across the country were being able to leverage every provider across the system, and surgery centers, since they weren't providing essential surgeries, could provide some overflow services that a hospital may not be able to provide. But that's a great example of, it's kind of bringing up the question, if they can do it in an emergency situation, can they not? Is there some role for them to be able to play? And I think that creates a more competitive environment, and where there is competition, the consumer always wins in terms of lower prices and better quality of care. So those are some things that we continue to look at. That's only one of our areas on site neutral payments and building a competitive marketplace. We've tried to also change the reimbursement for doctor's visits and in hospital outpatient settings, make sure that those are more equivalent with doctors' offices as well. Again, all towards trying to make sure we have a level playing field and we're increasing competition.
And in turn, supporting more value and getting to a more resilient healthcare system that provides access and low cost. Administrator, thanks very much for joining us today. Seema, it's great to see you and appreciate all the hard work you're doing for the country. Thank you very much.
Thank you, Mark. Great to be here.
Okay. And now I'd like to turn back to Andy Slavitt to go to our first panel about some of these value-based approaches that are being implemented now.
Yeah. So far, all you've gotten to hear from our 3 government bureaucrats, 2 ex and 1 current. So now let's get to the real world. I think Mark and I think both feel like the hallmark of where things get done or need to get done is out with people who are really doing it. So pleased to have, I think, 4 really terrific people, friends who are going to be on the panel. And I'm going to allow them to do a better job than I am introducing themselves to organizations. But Griffin Myers, Griff, are you on? There you are. From a phenomenal organization called Oak Street Health that's doing some really innovative things in value-based care and also in health equity. Tim Lash, who I think you may have seen on earlier, from the Gary and Mary West Health Institute. And you'll hear from Tim, I think, about a lot of the forward-looking work they're doing in value-based care. Ryan Knopp, who I have not yet met, but I'm excited to meet for the first time because I've heard a great deal about Stone Cook, which is a family physician, which is a family practice doing value-based care. And then my dear friend, Mina Seshamani, who served in the Department of Health and Human Services along with me, is at MedStar Health and is one of the people both responsible inside and outside the government for moving in the direction of value-based care. So why don't we start with, maybe I can ask each of you to spend 2 to 3 minutes, and let's go in the order that I read your name. So starting with you, Griff, on what your experiences are with value-based care, and if you can focus a tiny bit on how that's helped you respond to the COVID-19 crisis, that would be terrific.
Yeah, for sure. First of all, thanks, Andy and Mark, for having me on behalf of the team and our patients. I figured what I'd do for folks is give a quick overview of Oak Street and then talk about, you can't really divorce the value-based care approach from our model because it's core to what we do. And then we can talk about the way that equipped us to better support our patients throughout the early phases of the pandemic. So we at Oak Street are a de novo, fully value-based network of primary care practices focused on Medicare patients and dual eligible patients around the country. We operate 56 centers now in 8 states, places like Chicago, Detroit, Indy, Philly, Cleveland, Flint, Michigan, Memphis, Tennessee, Providence, Rhode Island. We have the privilege of taking care of about 85,000 folks at this point. And if you think about it, it's about half dual eligible. That's a little bit high, but roughly speaking, about half dual eligible and about the half Medicare. And we're fully value-based. So it means that our relationships with our health plans are all full risk. And we do operate an ACO for the small number of folks who are not on managed care, and obviously look forward to CMMI's new model in direct contracting. Transitioning now to the pandemic, you really, like I said, can't separate a value-based model from the way that we take care of our patients. So our revenue didn't change at all. Our obligation to take care of our patients, regardless of circumstance, didn't change at all. We kind of went through 5 phases. The first was really, we recognized the magnitude of the pandemic, created a response team, which combined executive and operating leadership with clinical operating leadership, and established communication lines with the teams. And then really the rest of that phase was securing PPE and building the protocols to be sure that our teams were safe. And luckily we had enough of those materials in-house to really focus the team on using them appropriately. Phase 2 is move our patients home. Just to give you a sense, we were doing about 1,800 primary care visits a day. and transitioned very, very quickly to where all of those patients were home and we're doing care then nearly totally remotely, about 93% of visits with our team still being in the center. Then about 3 days later, moved the rest of the teams home. So phase two being got the patients home, phase three, we got our teams home. We did keep our centers open for rare in-person visits as required, but really, especially at the height of the pandemic, moved folks home. And by the time we'd made that full transition, we went from about 1,800 in-person visits a day to about 2,200 visits a day, 93% of those being in some form of video or on the phone. Phase four then was to augment that. To improve the quality of the video experience, we launched what we called COVID Care, which was our in-house disease management program for those with confirmed or suspected coronavirus infections. Increased the amount of remote monitoring we were doing, especially with pulse oximetry. Turned up the number of home visits and in-home care. And then last, adding a tested capability. And I think the piece there that our value-based model really allowed us to do was we were doing about 5,000 wellness checks a day, delivering then food, toilet paper, medications throughout, just because we knew that's what our patients were relying on us for. I know we're going to speak a little bit later about outcomes, but for us, we follow pretty religiously our hospital admissions per 1,000, emergency department visits per 1,000. And we can talk later on about that. But really, we did certainly in our neighborhood see COVID cases, but far more of the morbidity and mortality that we've seen in excess of our baseline is not directly related, but rather an indirect effect, something that while small was material. And I'd fear to world what it would like without the movers we put in place. And I think just to wrap it up, I will say, we were able to pivot entirely. This was about what was best for patients. The financial impact will come later, but I think like many observers has seen our third-party medical costs has been down as folks lack access to care, and that's something we got to go fix.
All right, Griff, I'm going to come back and ask you about some of that, but let's go to Tim next.
We're unmuted. Andy, great to see you, and it really is a privilege to represent the Gary West PACE program as well as West Health today. For those joining the webinar that aren't familiar with PACE, PACE, or the Program for All-Inclusive Care for the Elderly, is essentially a fully capitated risk-based model that targets the frailest amongst us, the most vulnerable amongst us, and individuals that otherwise would qualify for care and services in an institutional setting. And COVID-19 really illuminated the need to have such alternatives. We launched this program in collaboration with our medical research organization, the West Health Institute, because we saw two real opportunities. One, to really examine and redefine from the ground up PACE itself, with an eye towards scalability and sustainability, to define the gold model, to share those learnings with agencies across the country in hopes of reaching more patients with this critical and needed model that generates superior outcomes. But perhaps more importantly, we saw an opportunity in studying what works in the frailest and most complex patients to define the efficient frontier of services, utilization, and outcomes to start to migrate upstream to less frail, less complex patients, and really start to address many of the major perils, flaws, and inequities that exist. And here too, C19 really illuminated the need for that, but also simultaneously provided an opportunity for us to accelerate that. And Andy and Mark, I've heard you use the term hyper-parallel as it relates to the drug development that's happening for COVID-19, and where you have a series of steps that are typically done in sequence that are all happening, everything from the development to the testing to the commercialization in parallel. And we had to take a hyper-parallel approach to redefining the legacy model at PACE in terms of what it means to deliver timely, efficient, and appropriate care. And I'd like to highlight, sort of two areas that we really focused on as it relates to challenging the historical thinking. The first relates to the setting of care. PACE historically, and really, our healthcare system is very institutional based. It's brick and mortar in buildings. And, we realized very quickly if we were going to protect these frail seniors, that we were going to have to project care into the home. And as such, we moved very quickly to introduce, telemedicine and virtual models. And one of the learnings for me there was that, often when we think about telemedicine, we think about the sort of the bleeding edge of sexy technology and auscultation and various sensors and sort of more advanced technology. And for us, what's proven to be quite effective is a camera, in some cases scale, but most importantly getting the workflows right. Thinking about how one introduces the technology into the home for the participant, how one coaches their caregivers on that, and then how we support our staff in deploying the model effectively. The second area that we were really focused on was the team. In redefining what it means for us to have an interdisciplinary team. And here also we had to take a very virtual approach to deploying our assets. And what we found was that during a pandemic like COVID, our bench was our greatest weakness. As a smaller program, you really had to think about one, just protecting your team, their mental fitness, protecting them from exposure to COVID itself, but also exploring options to ensure that we had the agility to flex our capacity as needed. And what we found is that a contracted workforce and being able to access contract providers, whether virtually or physically, was an absolute imperative for us to meet the needs for our participants. And I'm glad to report that by sort of moving quickly on both of them, we've only had one positive COVID case.
Dr. Knopp, love to hear from you next.
Sure, happy to be here. Thanks for putting this on today, and privileged to be part of it. So I'm here in Manhattan, Kansas at Stone Creek Family Physicians. We're a group of 11 family physicians, 2 PAs, a staff of around 50, caring for nearly 20,000 patients here in Manhattan, Kansas. And just to give you a sense of our journey and maybe the voice that I bring to the table this morning, I will tell you that 5 years ago, we really had no idea what value-based care was. 4 years ago, part of a hospital-based ACO that, quite frankly, was a failed experiment. And then in 2017, we joined an ACO that partners with independent primary care practices across the country by the name of Validate. And I know many of you are familiar with Validate and the work they've done. They're currently partnering with over 7,300 providers across 27 states and just over 840,000 lives under management. So flash forward to now, 3 years into this journey, and now I sit here as a believer and a passionate advocate for value-based care systems, where we've really seen the phrase good for patients, good for doctors, and good for society really come to life for us here in the Midwest. So my message today is that, even practices like mine in Kansas, in the middle of the Midwest, who are really just beginning to dabble in value-based care, are uniquely positioned to navigate really any situation that medicine throws at us now, even a pandemic, because of some of our value-based care capabilities and workflows. And to illustrate this, if you want to humor me just for a minute, let me share a patient story. So I'm going to tell you about a patient of mine whose name I'll call Joe. High-risk patient due to age, COPD, end-stage liver disease. Through our Validate app, we identified him as one of our many high-risk patients on what we call the COVID vulnerability list. And of course, with low volumes in our office in March and April, we engaged our clinical staff team to rally around outreach to patients on this list. During our phone call with Joe, we learned that he was having worsening abdominal pain, fluid buildup, or ascites to the point of not sleeping, and right on the doorstep of going, because in his words, he didn't want to bother us and figured we had our hands full during the middle of a pandemic. So that call turned into a televisit with me, and then we promptly addressed his pain management and facilitated a therapeutic paracentesis, and even circled back to some advanced care planning, sort of end-of-life conversation. So, in this story, I use it to illustrate the very value-based care themes that we've learned over the last 3 years really came to the forefront. In other words, data led to identification of a high-risk patient, team-based care led to outreach, outreach led to access, access led to high-quality patient care, which ultimately resulted in a televisit, which in the moment financially supports our practice. And then, of course, we could foresee some reduction in cost to the healthcare system by avoiding an emergency department visit for that particular patient. And then you flash forward down the road and say that will then generate shared savings dollars for our practice next year. And by the way, that is exactly what's helped keep us afloat, really, beyond the much appreciated payroll protection program loan and healthcare stimulus dollars. Our shared savings reward now 3 years in a row from our Blue Cross Blue Shield of Kansas commercial contract. This will be 2 years in a row for our MSSP Medicare contract. Those shared savings dollars absolutely have been critical to keeping our practice fully open and functional and providing access during these times. So as I reflect on these last 3 months, I've recognized really that we've had 3 major challenges, and that's patient care challenges and resource support challenges and financial challenges. And out of these, of course, were born new workflows and new collaborations that many have alluded to today. Really, in each case, we've been able to leverage our value-based care capabilities to help us overcome barriers and succeed. So I'd be happy to expand on those and answer some questions here just in a minute.
Great. So Dr. Seshamani, a very different size organization that you are a part of. Talk about your experience here.
Yeah, so thanks Andy, Mark, and the team for having me. So as Andy mentioned, I work at MedStar Health, which is a health system in DC and Maryland and Virginia. So in contrast to some of the other presenters, we have 10 hospitals, 9 acute care hospitals, 1 inpatient rehab, 300 outpatient clinics, 3,000 physician medical group, urgent cares, visiting nurse association, et cetera, all under this umbrella of a distributed care delivery network. So in 3 minutes, it would be difficult for me to go through all of the things that we have done around our COVID response, but I thought I would provide 3 examples where we have been engaged in value-based care arrangements and how they have helped us with the COVID response. So the first is our Independence at Home demonstration. So we have geriatricians who have been involved in home-based primary care for frail elders as part of the CMMI demonstration. And with that, have really achieved a level of comfort and relationships with caring for patients across the spectrum, be they at home, coming into the hospital, in our skilled nursing facilities. So enter the COVID crisis, and as I believe Administrator Verma had mentioned, there were significant issues with COVID in the nursing homes. And we are in a position with our relationships to support those skilled nursing facilities, providing help with infection control, how they use PPE, and through a telehealth platform, be able to partner with the skilled nursing facilities when there are concerns about their patients, to be able to take a look, provide assistance, and provide expedited transfer to our EDs if possible. But really try as much as possible to prevent COVID, and if a COVID crisis does happen, to really collaboratively work with them to help manage. A second example is palliative care. So I think, as all of you would think, when you have a serious illness, it's very helpful to have a team-based approach where people really speak with you and relate with you as a person, as a member of a family and a community, in figuring out what your goals of care are and how you want to be cared for. And that oftentimes involves a chaplain or a social worker, and people who don't traditionally get reimbursed in a fee-for-service payment method. So we have been working with our payers on payment models to really reward the value that our palliative care providers deliver, especially since it leads to reduction in unnecessary utilization, improved symptom management, patient experience. So again, enter COVID-19, and we were able to create a screen tool in our electronic medical record to identify patients with serious illness early in their hospitalization, to be able to talk with them about what their goals of care were, and to be able to provide support to them and their family members in the setting of visitors not being able to come into the hospitals. We were also able to leverage telehealth here, creating a telehealth bunker, if you will, where we could provide these services across our hospitals. So we were able to expand capacity by 25% to really enable that reach of our chaplains and our social workers across our system. And notably, when doing it through telehealth, then the provider isn't wearing a mask. So rather than having a patient having a difficult and tough conversation about their care with someone who's looking at them like this, you're actually able to see the full face and really engage in what can be some very emotional conversations. And then the third example I would give, we are part of the accountable health communities with CMMI as well, where we have community health workers that provide health-related social screening linkages with community services for food insecurity and other social determinants of health, as well as Maryland Primary Care Program, where we have care managers who provide care transitions and longitudinal care management. And I think has also been mentioned, the COVID crisis certainly has exposed the health inequities, disparities, and the role that social determinants play, both in the pandemic, but then also for care outside of COVID. And we were able to quickly mobilize our community health workers and our care managers to not only reach out proactively to our high-risk populations to make sure that they are able to isolate, that they have the food they need, the medications they need, caregiver support. But then also, when patients do come to the hospital and have COVID, upon discharge, we created a discharge protocol whereby transitional care nurses followed up with patients, made sure there were pharmacy referrals where needed, home health referrals, community health addressing social needs, such as if they need food. Because when someone has COVID, they have to go home after being in the hospital for a while and isolate for 2 weeks. Do they have food in their house? Do they have the medications they need? And all of those things are important for us to best address this pandemic. So we were really able to leverage that as well to care for people across that spectrum.
Great, thank you. So let me direct the first question to you, Griff. If you were a fee-for-service entity and not a value-based care entity, then if there was decreased utilization, instead of the money sitting with Oak Street and allowing you to invest it in prevention and telemedicine patient health, who would have had that? Where would that money have been?
So it's funny you ask, right? I think that, we started the organization to be a fully value-based organization, and it's some of the bad habits we never had to learn with regards to fee-for-service. So there was never a question when the pandemic began to unfold that we were just going to pivot what we did and use the resources that we had to provide a different level of care. I don't mean to miss the mark, but if we had to find a way to drum up fee-for-service volume to keep things afloat, we just wouldn't have made it. But we're so far down this other path now, we've never done anything else. Maybe I'm missing you here.
So I think what you're saying is the insurance companies would have kept those premiums, and they wouldn't be with the care provider.
Yeah, for sure. I mean, so in our case, timing of actual payments is a little bit different with each health plan, but you're right. It's a full risk, globally capitated model for all parts A, B, and mostly D in most contracts. In which case, that means that we know upfront what the premium is going to be. That our target is to deliver incredibly high quality care and to do so in a high value way as well, where we can come in below that benchmark and save it. And it meant that there was no question when we pivoted our entire outreach team to making wellness phone calls and transitioned our care teams home to do video visits in a team-based fashion. I like what Tim said before about getting the workflows right. Once you get those workflows right, you're back at it taking care of patients. And some of these things we'll keep because this experience taught us some new things that work for patients. We'll go back to an inter-center model for sure, and have the flexibility to do that, but recognize the value of this remote care as well.
Yeah. So question for you, Tim, which is, without the knowledge of gain share payments for delivering higher quality care, would you have been able to afford to invest in the patient population, or would you have been more hamstrung?
Yeah, a great question, and I think we would have been more hamstrung. And the investment in this patient population under COVID-19, I think does highlight some of the limitations of the program that can threaten the very viability. And specifically, we modeled early on because we had a responsibility to understand how viable our program would be in the face of this pandemic, what our financial exposure looks like. And for PACE, the capitated payment between Medicare and Medicaid is essentially $86,000 a year, plus or minus a little. But when you look at the population that we're serving, if we didn't get the virtual care, right, if we weren't able to isolate the seniors and project care into the home, we could have seen, COVID rates, at 50, 60%, where we modeled mortality at north of 75%. And that's a tragic human consequence, but the financial consequence of that is perhaps even more dire, in that it could threaten the viability of this program and other programs across the country. PACE is generally a small population of patients. It's a very homogeneous population of patients, and they're all incredibly high risk and frail. And in the face of C-19, not only do you need to have challenges as it relates to care, but you have challenges as it relates to your just ongoing viability. And as I think about policy options going forward, there's been a lot of discussion for next gen ACOs on limiting the upside potential, and it's now 5%. But as you look at some other capitated models, there does need to be consideration on how do we protect them in the face of these catastrophic events, because without that protection, organizations may choose, not to make the investments that could really transform, the lives of participants and their families.
Yeah, that's right. And I think one of the things that is, if you were not able to make that conversion, that maybe you could help explain to folks about the PACE model, is what that would mean for people having to be reinstitutionalized or institutionalized into nursing homes, and the safety or safety concerns that go along with that.
Yeah, so as I offered earlier, for participants in PACE, they otherwise would qualify for care and services in an institutional setting, like a skilled nursing facility. And PACE was a lifeline for these participants during COVID. In fact, as a leadership team, we had early discussions on what is our responsibility to the financial viability and the risk that onboarding new participants sort of presents, now knowing what we know, versus our obligation to deliver services at a time when these individuals need them most. And you have to have the discussion, but we made the right decision, which is we will recruit and we will be there and we will provide those services because they need them. And the alternative is a skilled nursing facility where across the country we've seen quite frankly horrific outcomes in some cases. But in the spirit of partnering with a medical research organization, we've taken the workflows and the learnings from technology, and we've already started to move them into partnerships with skilled nursing facilities and with EMS systems locally, so that you can have that urgent, appropriate, efficient deployment of care, and you can treat in place as needed.
So, Ryan, given your practice size, if you went back to that practice 5 years ago, which you talked about, compare what kind of patient care you would have been able to deliver, what decisions you would have had to make if you were that practice of 5 years ago that was pre-value-based care delivery.
Yeah, exactly. Well, in general terms, we would have been ill-equipped and likely failed miserably, but specifically, it would have been, we pivoted to telehealth overnight. We had a resource and guidance from Valuebased, who's been a great partner through this. I do not think we would have been able to get telehealth up and running that quickly were we not part of Valuebased or a value-based care arrangement. And then you still have to understand, even now compared to, 5 years ago, we still operate in largely a fee-for-service realm. So 5 years ago, that would have been it. We would have been kept alive as a practice by the payroll protection program loan and healthcare stimulus dollars. But as of right now, meaning 2 to 3 months into the pandemic, that now runs dry. And then we would be faced probably with some significant prospects of furloughs and staff layoffs and really downsizing our clinic just because we'd not financially be able to make it work. Of course, with the value-based care arrangements now, we're able to use those shared savings dollars, as I alluded to earlier, to keep the operation running smoothly. And then 5 years ago, we just had no concept of what value-based care meant in terms of team-based care, proactive patient outreach, population health management, all these things now that have become part of our core workflow. When you don't have those things in place as a foundation, it is really hard to pivot, and take care of your patient population overnight like we've done here otherwise now.
Got it. So, Mina, I guess I'm going to call you Mina just because I always have. Your organization and you personally are committed to health equity and to addressing the significant disparities that happen in our healthcare system. Can you talk about what in a purely fee-for-service world where you only collected money for people walking into one of your facilities versus a world where you have some capitation, some other flexibilities and some payments, how that impacts your ability to address health inequities, and how much, take that, since you've been a policy person, take that to the level of the country a little bit. How might you suggest that these issues might be met, given how much racial disparity there is in healthcare delivery and outcomes?
Sure. So in a pure fee-for-service world where you get paid when someone comes in your door and you provide a service, there really is no incentive or opportunity to figure out why that person was coming in your door in the first place. And do they really, is there something that we can do to keep them healthy so that we're taking care of them before they actually come in? And I think this is where a lot of the activities around value-based care and population health come into play, because without that, you wouldn't have the opportunities, for example, for our Baltimore hospitals to partner with Baltimore police and other community organizations for our Safe Streets program to prevent gun violence. Because instead, we would just see the trauma victim when they come into the hospital, and we would take care of them, and that would be that. And instead, to be able to move beyond to where a lot of this originates and really think about providing health care rather than sick care, I think is very important. And I think, the COVID crisis has certainly identified the health inequities and disparities. And, there are also opportunities when you have the economic crisis, colliding with this public health crisis. There are opportunities to, for example, train and employ community health workers from the very communities that are being affected most by this crisis, so that they can in turn provide support to those communities. And they're going to provide support to those communities way better than anyone else can. And so where can we create those win-wins where we can create jobs, we can also then provide the support and the avenues to address some of these issues that have led to long-standing health inequities, that if you just were to look from that fee-for-service lens, you're only going to see when it gets to the very top. And you will not address that's the tip of the iceberg, and you will not be able to address what's underneath. And what we need to do is address what's underneath.
Do you think you could publicly report outcomes based on top and bottom quartile of income by race, by zip code, by gender, by ethnicity? And do you think that's a good idea as a measure for us to be using for reimbursement and care delivery?
I certainly think that social determinants play a role in risk adjustment with our value-based arrangements, just like number of chronic conditions, et cetera. And it is important for us to look at that. Again, specifically with COVID, a lot of the data that is coming out is looking at how the people affected breaks down by income, by race, by geography. And I think that's critical for us to be effective, because then you know where to target, and you can figure out what you can do, again, to be creative of what you can do to help in those particular areas. If you don't have that kind of data, you're kind of shooting in the dark. And instead, to be able to be more thoughtful in how we approach the issues at hand, using the data to be more actionable is really key.
Yeah, I guess the question that I have and that I had at CMS was, how often were we using social determinants and as a bailout for providing inferior care to Black communities and poor communities, and how much that allowed us to continue to allow that gap to exist. I don't know if you have a comment on that, but while you think about that, I'd love to just circle very quickly through Griffin Tim and Ryan to also answer the question about, I think it's very much a topic of the moment, how you would feel about publicly reporting outcomes by race, and what good you think that would do.
Yeah, I mean, I will say it definitely has been a debate in terms of how those social determinants data are used, and that you don't want a pass, if you will, on inferior care. I think having that data shines a light on where there are opportunities for investment. And I think that's very important for the data to be used in that regard.
Great. Great. Any comments from you, Griff?
Yeah, I mean, this is what we built the organization to do, was to go to communities and invest in exactly this way. And I think, you know, we don't think about it this way, but in healthcare we call it value-based care. Economists just call it a functioning price mechanism. And we have such an opportunity for improvement in so many of these communities that the marginal dollar should and can and will in these models go to communities that need it the most, because that's where the biggest opportunity is. So for sure. And frankly, I'll say, Andy, like, I was doing some work the other day with one of our teams. It's sometimes hard to find the data that you're looking for and understand how these things split out, even in crude measures like dual, non-dual. Some of that stuff's hard to find. So I'd love to see us report it.
Tim?
Sure. You know, Andy, we launched the PACE program in collaboration with the Medical Research Organization, which is a nonprofit, because we're committed to sharing the outcomes, sharing our learnings when they're positive, when they're negative, and sharing what works and fixing what doesn't. When I think about where we're heading with PACE and with the learnings, perhaps the one thing that I'm most excited about is extracting some of the learnings around telehealth to address the broader inequities. West Health just did a survey with the Gallup organization, and we asked people across the country whether they would avoid treatment for COVID if they had key symptoms, a fever and a dry cough, because of concerns of cost. And 10% overall reported that they would. And when you look at the Black and Brown community, it was 22%. And I think what this highlights is that while these inequities, are pervasive and persistent, in our society, and historically, when you look at, higher rates of cardiometabolic disease, diabetes, cardiovascular disease, the impact on outcomes of those inequities plays out over years to decades, right? And in a COVID-19 environment where you have people delaying care because of concerns of cost or limited access, that plays out over hours to days, and it's sometimes fatal. And it's something we can't tolerate, but I do think it's something that, as we look at aspects of all of the value-based models that we're discussing today, and particularly the ability to project care into the community and treat in place, that we can leverage those learnings to make a meaningful impact. But there probably does need to be some deep policy reform to enable that.
Got it. Ryan?
Absolutely. And to answer your question directly, Andy, the answer would be yes. We'd be fully open to that. If there's anything we've learned on our Validate journey and value-based care journey in the last 3 years, is that data absolutely will guide action, and transparency is always the best model to move forward with that. I think as we sort of navigate this reopening plan and sort of where the country goes on what I think will be the roller coaster of the year ahead, I suspect that a lot of our workflows, we're going to need to repivot. We're going to need to catch up on preventative health services and deferred care that hasn't gone on in the last few months. And there is no time like the present to reinvest in our work around social determinants of health. And again, we always believe in transparency around that. So happy to answer that and happy to be part of this conversation.
Great. No, that's super from all four of you. And you may not have seen it, but one of the United States of Care board members, Rhonda Meadows, produced a 5-point pledge for addressing COVID in the Black community, which is everything from testing to prevention strategies around high blood pressure and diabetes, to ensuring that we index our vaccine distribution to the communities with the highest case fatality rates. So we can get, anybody who's interested in that can connect with the people at US of Care, and for all of you. Well, look, I really appreciate all four of you coming on. I appreciate what all four of you are doing. After listening to you, though, what I really want to say is I appreciate what you all are doing for your patients and your communities. I know enough about each of your organizations. And I think that as Mark and I and the rest of us talk about value-based care models, the one thing that doesn't work is overlaying a value-based care model on an organization that is just not in it for the best results for the community, but is only in it to figure out how to find a payment model that pays them more. Somehow, they may be able to get paid more, but in the process, nothing gets better. And that just bastardizes the value-based care model and turns it into another version of fee-for-service. So I think we are sending the message here today, and I think you heard it from the administrator. I think you'll hear it next in Mark's next conversation with Brad Smith, that we have an opportunity to put the ball back in the court of all of you instead of the people who are financial intermediaries, and in so doing, strengthen, I think, your resiliency, your ability to deliver care in all the ways that you guys talked about. So thanks so much, and I'm going to hand it, I think, back to you, Mark.
Great. Andy, thanks to you. Thanks to all of our panelists for a terrific discussion on how to address some very important challenges around quality of care and access and disparities, not only doing it in the context of COVID-19, but moving forward on these issues. So I'm very pleased now to turn back from the front lines to one of those bureaucrats, but this is a very special bureaucrat. Brad Smith is the director of the Center for Medicare and Medicaid Innovation. He's formerly the CEO of Aspire, which is another value-based organization focused on improving care for people with advanced illness. And Brad, very pleased to have you with us today. I know CMMI has been busy. It's been an important force for the development of many of the value-based care models that you're seeing in practice right now among the panelists on the previous session, and I've been very busy during the pandemic and keeping these kinds of activities moving forward and adapting them, and as we'll talk about, potentially building on them. But just to get started, you're relatively new at CMMI. You started in December, just a few weeks before the first cases of COVID-19 were detected. Could you talk a little bit about some of your goals and aspirations coming in, and then what happened when that met the COVID-19 reality?
Yeah, for sure. Well, first, thanks for having me, Mark. Really excited to be participating today. So you're exactly right. So I started in January and, really came in being excited to build on the great work that, Patrick and Adam and others here had done, and you and many others, and kind of move the ball forward. And so really started in early January by diving in deep on all the different models we had. We have about 40 different models that we'd rolled out. Had started kind of going through budget reviews of each models, all the evaluation reports on each models, meeting with all the model teams. And we were just getting ready to kind of roll out our plan for the year, literally right when COVID hit. And I think, I want to say second week of March, Adam called me. He was going over to the White House to start helping on COVID. And so I kind of got sucked into that work full time. So spent really until maybe a couple of weeks ago, the better part of the last 3 months, really helping with the COVID response, helping with scaling up testing, helping with some of the work we did around supply chain, flying in supplies, et cetera. But really over the past month or so, I've kind of slowly been moving back into the day job at CMMI and really thinking about kind of where do we go from here. And I think, as we'll talk about more, in some ways, not much has changed, and we're still very committed to doing all the things that we were thinking about in January and February. But at the same time, want to be really thoughtful about what's happened with COVID and how we create appropriate flexibilities for everybody related to that.
Yeah, well, we're certainly appreciative of all you did to help with the surge response, but also glad to have you back in guiding these next steps at CMMI and in value-based care. Maybe you could start by, I want to talk about what's coming next and what your thinking is, but maybe you start by what you're seeing out there. So we just heard from some panelists who are involved in many of your existing CMMI models about what they've been able to accomplish. Have you seen similar things? Because it really does seem like a different world for providers who are in these models versus those who have been in fee-for-service during the pandemic.
Yeah, I think that's exactly right. I think, what we've seen in the evidence around a lot of our models is a lot of practices and a lot of hospitals have really transformed how they practice day to day. And I think some of the things that they were doing before the pandemic about putting in place care coordination, regular touches with their patients, more care in the home, all of those types of things ended up being really important during the COVID epidemic. And so I received a number of different emails and anecdotes from all across the country over the past 3 months, talking about how some of the changes that folks had made because they were in ACO or because they were doing a bundles program, and they have been able to quickly apply some of those lessons learned for COVID. From a financial standpoint, I think we saw some of that. About 30% of the country today is in some version of value-based payments, but it's still a pretty small percent, single-digit percentage, from your work on the land, that are really in sort of fully capitated two-sided risk. So even though I think from a care coordination perspective, it was able to be really helpful, I think there was some help from a financial perspective, especially for those folks who were in capitation, but maybe less so for some of our folks who are moving towards value, but maybe not as far along that spectrum yet.
Yeah, and in terms of where we go from here, so Administrator Verma talked about the general commitment remaining at CMS and moving to value-based care. You're on the point for that, and recently you announced, just last week, a set of next steps in many of these programs. They've generally met with positive responses from the value-based community out there. I'm wondering if you could say a little bit more about what's been behind your thinking on how to adapt the models to the current context.
Yeah, absolutely. So maybe I'll kind of start from the big principles and get more specific. So I think at the highest level, we had really two goals for the model changes that we made. The first is we wanted to make it really clear that we were committed to moving forward with value-based care, and that while the pandemic had changed lots of things in lots of different ways, one of the things that hadn't changed was our commitment to value-based care. And then I think the second thing we wanted to show is that we can be a really good partner to participants. So when providers enter these arrangements with us, obviously none of us could have expected what's happened over the past few months. And we wanted to show that regardless of what was in the contracts or things like that, that we were good partners, that we were thoughtful. And hopefully folks felt that way. As you mentioned, the overwhelming response we've gotten has been really positive. I think what you generally see is that we tried to tweak things, not completely change where the ship was going. So, there were a number of models where we pushed out some timelines a little bit, but typically not a year, typically a few months to account for the month delays that we had. There are places for a short period of time, we've lowered some of the reporting requirements to decrease burden on folks. And we've made different changes to the risk arrangements in certain situations where it was appropriate to kind of mitigate folks' risk, especially related to COVID patients and things that have happened during the public health emergency. So really tried to have a hopefully moderate, but really a good partnership with our participants around those changes.
And on those steps to mitigate risk, so as you know, these are models where providers, instead of just getting fee-for-service payments, have some more flexibility, but their accountability as well for things like total spending or spending over a whole episode, and for some important aspects of quality of care. Could you say a little bit more about how you are keeping that accountability in place, but also, as you said, helping to providers adapt to these unexpected costs that come along with COVID-19 treatments, which are hard to predict, the outbreak areas and so forth, and not something unlike these other care features that providers can as easily plan for in terms of care coordination or investments and new ways of delivering care.
Yeah, for sure. So it's a little bit specific to each individual model, but I would say, at the highest level in general, what we did across the models is, if there were patients who actually had COVID, we're in general pulling them out of the treatment group and holding the participants harmless around those episodes. Some of the trickier things for us to be figured out, and again, hopefully we'll be thoughtful around this as we go forward, is figuring out how, if at all, those things impact future year benchmarks. So we're doing a lot of thinking right now around how can we normalize for 2020 for the COVID pandemic as we think about 2020, or do we need to exclude 2020 from baseline years and trend over with the historical trend? So there's some of those technical details that we're working through, but I think in general, both for this year and also for future years, we want to make sure that our participants aren't unintentionally harmed by what's happened in the value-based arrangements with the COVID pandemic. And at the same time, we of course feel a balanced objective of making sure that we're being appropriate with the Medicare Trust Fund. And so really trying to make sure that we're hitting the right balance.
Yeah, and so those are important steps for organizations that are in this process of moving into value-based care now. As you know, for most organizations, they're still pretty much in fee-for-service and have really been hit hard under the pandemic. And from talking to a lot of organizations, I think there's some new interest or at least questions about what value-based arrangements might be available for them. Now, we have, Andy and I, along with some other former administrators, have a proposal that we released today related to this topic. And I'm not going to put you on the spot about that, but I would like to ask you but I would like to ask you about what should providers who are not yet in some of these CMS models be thinking about looking forward? I mean, they're getting some, and I think they need more financial support right now to take steps like what Seema was describing, telehealth, keeping patients like we heard about in the last panel, keeping their patients who are at risk in the community, out of nursing homes, out of hospitals, even if it's possible to deliver more advanced care at home or someplace that's safer and more convenient. Clearly, a lot of interest in moving in this direction too. What should those providers be thinking about?
Yeah, for sure. Well, I think if you take an aggregate what's happened over the past 4 or 5 years, right, you've seen the movement to value-based care last across administration changes. And now you're seeing it last through a pandemic of global proportions. And I think what that says is that the direction that we're moving in is here to stay and going to continue. And so I think, as we continue to launch new models, refine our existing models, our goal is to provide more and more opportunities for folks to move into value-based care. So one of the things we did, knowing that this year has been unique for a lot of folks, is try to create more opportunities with some of the model changes we made for folks to participate in the model. So for things like direct contracting in our kidney care model, in addition to having openings now, the direct contracting application period is currently open through early July. But we also added an additional time for folks to be able to apply next year to create, if they said, hey, we're still getting out of COVID, we might want to think about it more and apply next year. We're creating that opportunity. Same thing on primary care first. There'll be an opportunity next year as well for at least practices who've been in CPC Plus to apply. So I think that providers should expect to see opportunities for us for more ways to come into our models over time, for sure.
And again, I won't ask you to opine on this since it's just out today, but our proposal was really about helping with that transition. So as providers think about how they can get assistance today and take the steps that they need to take to manage in the pandemic, and we give them a clear pathway to getting into one of those models in the next year or two, and really help us get to a more resilient system. One thing I do want to put you on the spot on is this national attention, as we've been talking about throughout the webinar today, around concerns about racism and structural differences or structural issues leading to differential outcomes and health disparities for Black and Brown Americans and other groups. Seema mentioned a few others today too. Can you say a little bit more about maybe some of any comments, if you were able to hear the earlier discussion, or your thoughts about how CMMI and these value-based models can help address those really urgent but challenging issues too?
Yeah, I think it's an incredibly important issue, and it's always been an important issue, but things like have happened over the past couple of weeks only highlight the importance of it. One of the areas that I'm the most passionate about and that we've been working a lot on before I left and have picked back up since I've come back is really around social determinants of health. And looking at certain populations or subgroups, whether from a racial perspective, economic perspective, et cetera, where we see really big health disparities, and thinking about how we think about the things besides just their direct health care that might impact their health. And so whether that's food or transportation or economics, et cetera, and thinking about models around that. There's been a lot of innovation happening in this space over the past couple of years. Today, CMMI to date hasn't done a big model in this space, but we're spending a lot of time thinking about that, thinking about what our role in that might be, whether it's around making sure that we're getting the appropriate data and standardizing data for social determinants of health across the country, whether it's some kind of innovation in the payment model around that. So we have a lot of different ideas that we're thinking about, but I think the events of the past few weeks only make that even a higher priority for us.
And so it does sound like it fits with some of the discussion in the last panel about getting a better handle on differences by race and socioeconomic status, and a payment model is kind of directly around that. Other things we should be looking forward to, other things that, that you've got front of mind in terms of where CMMI goes from here?
No, I mean, I think the big thing we have been doing, and we were doing this in the early part of the year, was going through all of our models and really looking at the results those models have been having. And I think as we go through the rest of this year, you know, what we want to do is have more folks entering models, being able to scale up the models. And to be able to do that, you know, we have to show that the models are either saving money or improving quality. And so, you know, we have been going through and are going to be talking with the participants in models about where each model is on that trajectory, and making sure that we get them all on a trajectory to either save money or improve quality, because that's what allows us to expand the models and certify them to expand nationally. And we're deeply committed to doing that, because we know that expansion is critical for expanding value-based care across the country.
And CMS, CMMI are obviously a huge consideration for most healthcare providers in this country, how they get paid from you. But you're not the only part of the healthcare system, and I'm going to have a chance if we get on to the rest of this panel and putting some of the people from the private sector on the spot too about payment directions. You mentioned the LAN earlier. That's the Healthcare Payment Learning Action Network, which is a CMS-supported public-private collaboration around movements together towards reforming payments and supporting these kinds of models of care. Can you say a little bit about what you're seeing in the private sector, and maybe some opportunities for alignment and concerted action between CMMI and private payers going forward?
Yeah, for sure. So, I mean, I would just say I've been amazed by how receptive and interested the private payers have all been, and including the large health systems, but in terms of having conversations with us about how we might partner together. And what I'm very convinced of is if we can show that our models are either saving money or improving quality in a measurable way, I'm highly confident that private payers will come alongside us and either adopt the models or something very similar to the model. So I think the key for us is having successful models, because if we have models that are driving those outcomes, I'm confident the private payers will come alongside. One of the other things we've talked a lot with private payers about is obviously they've been innovating in this space for years now, and being able to learn from their successes, maybe some of their failures, but learning from what they've been doing and being able to incorporate that as we think about new models is also really important.
All right, Brad, thanks very much. I understand you're going to be able to stick around with us for a little while as we carry on with this discussion about broadening the impact of value-based care and payment reforms. And so thank you for this discussion, and thanks for sticking around. Be back to you in a few minutes. Right now, I'd like to introduce two other panelists for this discussion about broadening the impact of value-based care in COVID-19 and beyond. So we're going to hear some additional perspectives from a payer side and from the healthcare delivery side on how things are going so far, but also really try to be forward-looking about this, about what can come next. And we've got two experts here, very pleased to add them to this discussion on this topic. Will Schrank is the Chief Medical Officer at Humana. Will has a very distinguished track record before this, including, among other things, a stint at CMMI in its early days, and is getting going on exactly the kinds of things that Brad was describing, how to get to better quality and outcomes and lower costs through new kinds of payment supports. And Will is also key leader in the Healthcare Payment Learning and Action Network, that public-private collaboration. And also pleased to be joined by Toyin Ajayi, who is at CityBlock. She's the Chief Health Officer there, is one of the co-founders, and I'll let her tell you a little bit more, if you're not familiar with CityBlock already, about what it's doing in the front lines of all of these issues related to COVID-19 and racial and socioeconomic health disparities. Brad, Toyin, we're glad to have you with us, and I'd like maybe start with each of you with a few minutes about what you're doing, but in addition to what we discussed in the last panel, since this one's about looking forward, maybe we could start talking about where we go from here. So what are you doing, and how do you see opportunities to build on that? Maybe we'll start with you and hear about some of the activities underway at Humana, a major insurer in the Medicare Advantage space, private insurance for Medicare beneficiaries, about what's going on from the Humana standpoint and any reactions to what you've heard so far.
Great. Well, thanks so much, Mark. Good to hear you, Brad. And Toyin, nice to see you again. I'll just start actually at the outset. I'll focus on the payer perspective of Humana's book of business. As I think you guys know, we also have a considerable presence in senior-focused primary care and in care in the home, which are important contributions here in this discussion towards moving towards value-based care. But I'll focus here on sort of our position as a payer. And first, we just begin by saying how grateful I am for the incredible partnerships we've had over the last couple months. It's been a pretty extraordinary time where across the public-private continuum, there's been such deep alignment around figuring out how we can work together and deliver better outcomes, better care, more coordinated care, better access during this really, really challenging time. And it's been amazing to see the level of sacrifice across the board that folks have been willing to make to do what's right to care for patients. So for us at the outset, it was really a focus on making sure that patients had access to what they needed. So from a payer perspective, we eliminated very quickly cost-sharing requirements for COVID testing. We eliminated cost-sharing requirements shortly thereafter for all COVID treatment. But moreover, we really focused on making sure that there were no barriers. We simplified access to care, to primary care, and to managing comorbidities, chronic conditions, by eliminating cost sharing for all primary care, all telehealth, all behavioral health, try to make sure that patients were able to figure out ways to get access to the care that they need. We also sort of rapidly transformed our approach to making calls to patients. We make tens of thousands of proactive calls every week to our members. From focusing on sort of disease-specific interventions, we alter that approach to really ask patients, members, what their challenges are, and largely focused on social needs, social determinants, the true challenges that our members were encountering day in, day out. Next, we sort of moved our focus to issues related to capacity. And initially, it was more focused on in areas that are hard hit by, or that were hard hit by COVID. How do we make sure that we're not part of the problem? How do we get out of the way? And eliminated all prior authorization, all utilization management, all requirements for quality sort of documentation. We removed many of our staff from facilities just to try to make sure that we were in no way interfering with the rapid transition of patients into and out of healthcare facilities. But then it was increasingly clear that the providers in the marketplace are really hurting. So we had to think hard about how to partner with our providers in different and more progressive ways. And it was a lot easier in the setting where we have over 2/3 of our members are seen by patients who are in value-based contracts, nearly half of them with meaningful downside risk. And in those settings, it was a lot easier to figure out ways that we could be supportive. So we were able to either advance payment to providers based on expected quality bonuses, advance payment based on expected surpluses. And there was also advance payment just due to removing prior authorization utilization management. We were able to actually get over $1 billion out the door in a relatively short amount of time to providers who needed capital advances and more liquidity. The question about sort of where do we go from here, what's next? I'll say that we've gotten really, first of all, in terms of being more proactive and figuring out how we're part of the solution, we are deeply engaged in the analytics now of understanding who missed care, what happened to those people who did not receive the care that they needed, who are the people who are at greatest risk. How do we make sure that we act as fast and as directly and as effectively as possible on behalf of our members to prevent adverse events in the setting of this incredible natural experiment where so many people went without care? We're also laser focused on figuring out how to respond to the many providers out there, and we'll talk about this soon, who are now exploring and thinking differently about how to contract, and who realize that their partners, their colleagues who were in progressive alternative payment models with payers had a very different experience in terms of their financial experience, in terms of their ability to sort of satisfy their mission to really care for the patients they serve, their ability to be flexible and nimble and deliver the kinds of high-touch care that they prefer to deliver. It does feel like this is sort of a watershed moment, and that's an area that we're really, we're eager to join hands with Brad and others and figure out how we can sort of work together to accelerate that move towards value-based care.
Well, thanks very much. Toyin, good to see you again. I know very busy times for you all at City Block as well. Thanks for being with us.
Thank you for having me. So just maybe a little bit of background to respond to your question about who we are and what we see next. So City Block is a value-based provider. We enter into full risk relationships with payers and have a particular focus on an expertise in the care of high risk and rising risk members who are particularly dually eligible or Medicaid eligible. And so our patient population really represents typically the folks who are most vulnerable to disruptions in care, to fragmentation of their providers, to the impact of social determinants and social factors on health outcomes. And also, as we've been talking a lot recently, to the sequelae of structural racism and its impacts on health outcomes. And we have to remember that, as of 2018, almost half of dually eligible beneficiaries were racial ethnic minorities, compared with just about 20% of Medicare-only members. And so the race and the insurance status and the socioeconomics overlap certainly, but they can't be conflated with each other. And of course, our population also was incredibly susceptible to the impacts of a global pandemic like COVID-19. We operate in 4 markets. Pre-COVID, our model was tied very similarly to the model that Griffin described from Oak Street, to a combination of bricks and mortar neighborhood hubs. Those are spaces that we use to build trust and engagement and serve not just medical, but also social and behavioral needs of our population, as well as a very high touch in-person care model that's anchored uniquely, I think, to our model by community health partners who are non-clinically trained folks hired and trained from the communities we serve, whose role is to build trust and drive engagement with our members, who represent, as I described, a particularly hard to engage population with really complex needs, as well as a technology infrastructure underpinning everything that allows us to analyze data, to ensure that we can effectively segment our population, to help us identify unmet need, and to drive engagement forward. Our largest market is centered in Brooklyn, New York, where we care for several thousand members. And so when COVID-19 hit, we, like many of the providers you heard from in the previous panel, had to very quickly pivot our model from what was previously a very in-person, in the community, in-home model of care to primarily being virtual. We did this in parallel, of course, with all of the initiatives that you would take to pivot to video visiting, to make sure that our providers have all the equipment and training and tools that they need. But we also engaged in community forums with our members and their caregivers right at the very beginning. So we did one-on-one outreach to everyone and worked down a risk stack of our highest risk members. But we also did these public fora that allowed us to really understand what people were feeling and experiencing and what their needs were. And we heard very early on a few things that I think were pretty important to our innovation subsequently. We heard that people were afraid to go to the hospital. Very early in the outbreak, as the number of cases peaked in our most affected markets, folks had the experience of falling ill at home, being rushed to the hospital. Family members often didn't hear back from them for days, didn't know if they were alive or dead, could not get status updates because the hospitals were so overwhelmed that some of the basic functions of communication weren't being upheld. Folks heard of or experienced themselves high mortality rates, which further enhanced their level of fear and anxiety about accessing the hospital. And we also observed that, that there was a breakdown of a whole host of auxiliary clinical services in the community. So specialists were struggling to stay up with their members and connect with their patients and follow up with them. People were at risk for missing appointments. A lot of home health agencies did not have sufficient PPE to go into the homes and provide visiting nursing services and home hospice services. And we were quite concerned that we were going to see a subsequent pretty significant uptick in utilization and outcomes based on unmet needs for our population. And that was something that was really unacceptable to us. What we also heard from our members was that they wanted to know that there was a place they could call for reliable information at a time when there was just massive variation in the guidance that we were receiving from various government and non-government institutions. Understanding what the truth was, what one should do when they feel unwell, what the symptoms of COVID are, basic things like that. They were really hankering for a place to go for that information. And so in addition to moving our model largely from in-person to video, very similar stats to what you heard from the other providers on the panels in terms of the relative proportion of video visiting and virtual health and telehealth and remote home monitoring. We also scaled up our behavioral health support significantly. And again, this is something we're able to do because we were an at-risk provider in a value-based relationship. We didn't have to worry about, hitting up against utilization management thresholds for behavioral health visits or anything like that. We were able to provide folks with a level of behavioral health that they needed, both individually and in groups. We scaled up our virtual visits, of course. And then within 2 weeks, we actually built and scaled a whole new clinical program as an augmentation of our existing clinical model that was focused on the idea that we had to be able to keep people safe and in their homes, regardless of the level of complexity of needs that they have. So at baseline, our care teams were doing home-based visits for primary care, for care coordination, for medication reconciliation. And what we did was right at the beginning of the outbreak, we hired paramedics to our clinical teams. We equipped them, we trained them up, we built an operation around what we call our rapid response, community rapid response program. And we reached out to our members and said, okay, guys, if you have a problem, day or night, you can call us and someone will show up, a human will show up in your home within, our SLA was 90 minutes, but we were typically getting there within 40 minutes. It would be 2 paramedics with full PPE, with a full diagnostic set, with video telehealth communication in real time with either an emergency medicine doc or a primary care doc with urgent care capabilities, and we'll take care of you. And we did that because we as an at-risk provider knew that our population, A, was incredibly high risk for rapid deterioration if folks got sick with COVID or with other diseases, other illnesses, of getting very sick very quickly. And we wanted to make sure that we were able to provide the level of care necessary to stabilize them. And we also wanted to make sure that we weren't creating a scenario where, because there was this prolonged period of much reduced access to services within the network, that folks were going to start to present very late with things like heart attacks and strokes and terrible skin infections as a sequelae of having not had access to care. That program, we got up and running in 2 weeks. We scaled to our other markets and have been operating throughout the COVID pandemic and beyond, and have been able to, through that and through constant dialogue with our population, really make sure that we're meeting their needs. And again, this is how we've really taken advantage of our contracting structure and our clinical model to ensure that we're really there for our members. When we think about, sorry,
please go ahead. Please go ahead. This is a terrific set of steps. Yeah.
touch on what we think about the future. I mean, I think we're incredibly optimistic about models like direct contracting that allow us to align financial incentives and reward high value care, especially from Medicare beneficiaries who have complex needs similar to the population we serve already. We would be really excited and we hope to see persistence of some of the sort of interim measures that we'll put in place that allow for payment flexibility, for telehealth, payments for post-acute care in the home setting, et cetera. And so we're excited to see some of the things that we've learned through this persist beyond this crisis phase, because I do believe that it has enabled us entirely to be better, to better care for our populations.
Yeah, so it sounds like a tremendous amount to build on based on what you've done already. And just to push you a little bit on this last point, from the standpoint of CMS on the Medicare side, states maybe through their Medicaid managed care plans and their duals programs, any particular additional steps, or is all of this already on the right path with the opportunity for capitation and maybe the steps we talked about before towards more attention to socioeconomic, racial factors that can influence outcomes and that should be part of the further supports of these efforts?
Yeah, absolutely. I mean, I think that there's kind of widespread, and I think Brad touched on this earlier as well. There's lots of questions about how one prices risk in such a period of time with so much volatility in terms of the population, the morbidity and mortality, the difficulty in understanding what baselines are. We would just hope that this is not a deterrent to what we see as real sort of tailwinds in terms of the movement towards value-based care. And so would understand that the pandemic has certainly changed the underlying economics of how we think about some of these models. We hope that CMMI would start to account for these changes, helping create protections for COVID, getting more detail and understanding what risk adjustment models we're hoping to deploy as we think through, particularly direct contracting is a really interesting potential that we're excited about. And then to double click and just to emphasize on the permanency of other regulatory waivers and other new payment flexibilities we're hoping to see. Certainly telehealth is one, but payments for post-acute care in home settings I think is another really interesting and important space where we think about the risk that the nursing homes in particular pose to a lot of folks, and the opportunity to help people receive the same level of care with the right reimbursement structures in place in the home setting, I think could be a really powerful lever that helps to enhance and improve the level of care that folks can get in whatever setting they choose to be. And then certainly for folks starting to enter into some of these new models, thinking about how to make it easier for other providers to participate, glide paths and corridors and things like that. So I think there's a lot we can, that we're certainly hopeful. And I think there's a lot that can be done from a policy perspective to help us and providers like us who are really, really just fully committed to showing up for the population that they serve and making sure that they get whatever they need despite all of the challenges that we're facing as a community and as a country.
Thanks. And I'd like to take those comments and go first to Will, and hopefully if we can do this concisely to Brad. I know Brad especially is tight on time, but Will, you mentioned some steps that you're taking now in the way of kind of transitional supports and additional payments to healthcare providers who are really struggling, these additional flexibilities in payment. Can you say a little bit more about your thoughts of how to make that more of a long-term trajectory along the lines that a real pathway along the lines that Toyin was describing to help more organizations get going potentially and see a path to developing some of these same kinds of capabilities? And Will, I think you may be on mute.
You are correct. You are correct. Yeah, I have a lot of thoughts on this. There, in the short term, as we've been engaging providers, it's really clear that it's not as though providers are all looking for the same thing. There's this, pretty considerable spectrum of needs and challenges, and for many it was an issue of, for those who were not prepaid, it was an issue of liquidity. For many, it was an issue of PPE, and we had to sort of think about ways to contract and buy PPE for our providers. We offer different kinds of flexibility to get more rapid over-the-counter coverage for pulse oxes, as an example. So there's a lot of short-term things that we thought we could do, or that we did, and we had to be really sort of facile and nimble in how we worked with providers to try to address those needs, whether it's using our care management processes, whether it's using our efforts at addressing social needs and social determinants in communities. How do we wrap around providers and provide additional support? I think your question is sort of a broader one of where does this go in the future? And, I think there's a lot of demand or a lot of desire for using this moment as an opportunity to more rapidly transition to value-based care. And whether it's, a position from the federal government of relaxing or relieving some of the requirements to repay loans, or whether it's some sort of upfront funding to allow for rapid transition to a different kind of delivery model, those are all on the table for private payers too. A large private payer that's in the Medicare Advantage space absolutely is eager to figure out ways to partner with providers to help them more rapidly transition to value-based care. And for us to be, we really want to be partners.
And Will, do you see it as potentially easier to continue a lot of these flexibilities that have been so important, the telehealth, the site of service, the ability to wrap around providers as providers move out of fee-for-service for the longer term, when we're no longer in the the pandemic era, and as they're thinking about reopening a lot of the traditional fee-for-service types of procedures and delivery approaches?
Yeah, I think so. If you're contracting with a handful of small providers, their needs are entirely different, and they're much more interested in having support with care management. They're much more interested in having our sort of wraparound social determinants needs. They're really interested in having much more data that's already been has actionable and has been that's been evaluated already for them to give them actionable items. Whereas larger practices or more integrated delivery systems want raw data. So there's a broad spectrum of what what our partners want. Am I getting it? Sort of what you're asking?
And I think the point being that and partnerships to enable value are going to enable these kinds of models to care models to expand, and linking that to your payments. We had a couple of questions come in particular about how to make these kinds of approaches work for small providers that might be better for competition and keeping prices lower too. And it sounds like you're building that into your strategy looking forward as well.
I would love to hear our friend from that worked with Alidate who spoke earlier. I mean, in those settings, you need a lot of resources to wrap around those providers, but they, with the right set of resources, the evidence is compelling. So those are the providers that are able to, have the biggest impact in terms of cost and quality. So we as a plan are really, really eager to figure out ways that we can integrate and offer our services to help those providers deliver better care at lower cost.
Well, sounds like a path forward. And Brad, I know you have to run shortly, and we're running short on time, but maybe we come back to you on, based on what you've heard, some thoughts about opportunities to work with the private payers and a broader range of healthcare organizations to build on the value-based approaches.
Yeah, for sure. Maybe I'll start with some of the questions people had around flexibilities. So I think the way we're thinking about a lot of the flexibilities that have arisen from the pandemic is that, first CMS is going to go through and think about where they would want to relieve some of those flexibilities or continue them. And then I think of the ones that they decide not to continue in the permanent program, what we're likely to do is give a large number of those to all of our folks who are taking total cost of care risk. And so I think as we have more folks entering models that are total cost of care risk, we'll see those flexibilities expand. And, to your point of kind of more folks in value-based care, I think the key there for us is, one of the models that we've announced, making sure we create more opportunities for folks to apply, which we're going to be doing. And then two, I think it's really showing the success of our models, because as I mentioned earlier, I'm highly confident that when we can show that we're really driving savings or really increasing quality, that there's lots of private folks across the country who are going to want to come alongside of us. And I think the more of us that can align around at least common elements in models and in payment, the easier it will be for providers who don't have as many different ways they have to think about payment or as many different quality metrics they have to track over time.
That makes a lot of sense. And just for when you say total cost of care, I know there may be some smaller practices out there where that sounds really imposing, as Will mentioned, and as we heard about earlier, there may be partnership arrangements with enablers, others who can help these small practices do well. It sounds like that's what you have in mind and some of the special considerations you have for smaller practices, rural practices and the like.
I think that's exactly right. And we've especially been talking to a lot of those conveners as we think about especially rural health care and a few other areas, but absolutely for sure.
Yeah, Brad, thank you very much for joining us today. And Toy, I want to go back to you for maybe the last comment in this section, because I have to say this is in June 2020 with the pandemic, with everything we've been living through recently, and Black Americans have been living through for forever in this country. Not a lot of people who are using words like incredibly optimistic right now. So for talking to some of the healthcare providers who are really struggling with just getting through the pandemic, with the revenue losses they faced, and let alone trying to get a handle on the kinds of challenging issues that you all are really trying to get on top of and address. Any words for them? What should providers who are not where you are yet, but maybe thinking about new ways of responding to these really deep challenges in the pandemic and beyond, what should they be thinking about?
Yeah, I think that this pandemic and what we've been able to do collectively through the pandemic, and I should say I reserve my incredibly optimistic statement to thinking about how we build and rebuild healthcare. I can't say I feel the same way about the state of the world in general. But what we've been able to do during this pandemic as providers collectively, particularly community-based providers, demonstrates that truly what we believe to be true, which is that the system produces the outcomes that it was designed for. So when we choose to reimburse for telehealth, we discover that actually it is perfectly possible to provide actually quite good healthcare to a lot of people that doesn't require them to take a half day off work and find childcare for their kids and drive to a clinic and wait in a waiting room and. We can transform. And so when we think about even the limited transformation that a lot of fee-for-service providers have been able to do, namely from in-person to virtual, it says to me that it is possible to make change when policy and payment align, and when there's a clear set of incentives that are geared towards, at just a minimum, making sure that we're showing up and taking care of our patients. It also says to me that the conversations we're having around COVID, and particularly outcomes by race, ethnicity, says that we're entering into a new era in our conversations and our understanding of social determinants and also of structural factors, again, that produce the outcomes that we see all day, every day, that we've been bemoaning. I think that we are unpacking the underlying underpinnings in a much more robust way than we have in the past. And I'm optimistic that will lead us to create incentives, moratoria, frankly, a set of norms around the way that we think about care for our most marginalized communities that will be different in the future. And I'm incredibly hopeful that that providers like us who are, I think in many ways, as you described, kind of at the forefront of value-based care and of taking advantage of the flexibilities that it gives us to really radically rethink the way that we provide healthcare, have a moment when we can talk about what we do and we can share what we do. We've been, publishing blogs with all of our information as open source as we can make it, just to create the notion that there is momentum here and we can start to think about not returning to business as usual once COVID is done, but really building our system back better so that we are more resilient and hopefully less susceptible to just the horrible ravages of what we've experienced through COVID.
Toyin, thanks very much. I think leaving this panel on that note of resilience is a great place to end. Toyin, Will, Brad, thanks for being with us for this panel. I know we're right about at 2:30, which was our scheduled East Coast end time. The risk of going maybe 2 minutes over. Andy, I'd like to maybe turn back to you. Any final closing thoughts, and then we'll talk a little bit about next steps.
Yeah. Well, thanks, Mark, and all the panelists. I think I like ending on the note that Toyin ended on, which is both a realism, but a real practical sense that if we choose to, and if we have to transform, we're quite capable of it. And they would be ashamed to waste this moment. So I'll point back to the letter. Maybe you can remark on, Mark, that if we all pull together, federal government, state government, care providers, insurers, focus on one thing, which is the resiliency of our provider community and its ability to be able to take care of patients through the very difficult and traumatic times, whether those times are the coronavirus, whether those times are abject racism, whether those times are whatever comes next, we will serve our country better. And so thanks to everybody who does that every day, goes unrecognized, takes care of patients, delivers care. And thanks everybody for joining us on behalf of US of Care.
Yeah, Andy, I want to thank you and US of Care for this collaboration and in advance for the further work ahead. I think this theme of provider resilience and how to support it came through clearly. On the one hand, we've got a number of organizations who are being resilient already in this pandemic, who are taking some of the steps that lead to, I think, that sense of optimism that Toyin has, at least about the potential future of our healthcare system. But there are a lot who aren't. And Congress does need to take some further action to support them through this very difficult process. They're critical, not only for containing further outbreaks, but for helping meet patients where they are and get the care they need in this very challenging time and address these health disparities that are so urgent. But we know we can get there. What seems to be missing is the path. And as you said, we've got a unique opportunity, some challenges, but certainly unique opportunity with the opportunity for more financial support and a clearer pathway to get to those care models that CMS, that private payers are very committed to. We need to do it right. And hopefully this collaboration between US of Care, Duke Margolis, and many other healthcare organizations can help us get there. For those of you who want to know more and haven't looked at them yet, we have some resources available on our Duke Margolis website, as well as the US of Care website, about the kinds of proposals that we think could help with this transition. And you'll definitely be hearing more from us. And we'd very much like to hear more from you about what can work. We don't want to paint certainly a rosy picture of the opportunities to get from here to where we'd like to be with a resilient healthcare system. But we do have a unique opportunity, and we will try together to do the most that we can to take advantage of it and get to that better future. So thanks to all of you for joining. I'd like to give a thanks as well to West Health for their support for this webinar and for this direction of getting to more resilience through a very challenging pandemic and challenging times for our country. And a special thanks to our team at Duke Margolis, Rob Saunders, and the payment and delivery form team, Rachel Royland, Mark Japinga, and Will Blesser, and others, as well as Patty Green and Elizabeth Murphy. And we look forward to staying in touch with all of you as we continue to work towards better health and healthcare for all Americans. Have a great afternoon. Thank you.